Welcome to the Ortho Joe Show, a joint production of the Journal of Bone and Joint Surgery and Ortho Evidence. In our world, orthopedic research is king, and current topics from our respective publications are analyzed weekly. Here is Mohit Bhandari from Ortho Evidence and Marc Swinkowski from the Journal of Bone and Joint Surgery.
Well, hello, Marc. Nice to see you again. And I'm enjoying this really fancy new cup I've received. I know we've already talked about this cup, but let me just emphasize to our viewers that this is really a modern day cup for all uses, not just coffee, but it's, how you doing?
Yeah, I'm doing good. I'm only about halfway through this one, but I need to get deep into the second before I'm fully functional.
So, I've been scouring and thinking about topics we can discuss. And once again, I really am appreciative of those who are listening in, and giving us ideas. And we get lots of great ideas. And if you do have an idea, if you could just send us a note at orthojoe@jbjs.org. That's orthojoe@jbjs.org. So if you send us a great advice, we'll send you we'll send you a cup. And maybe I shouldn't speak over it, but if we how about this, Marc? How about this? If we use an idea, why don't we send someone a cup?
Oh, no question.
Is that doable? Okay.
Yeah, we might send two.
We might even send two. Look at this. The editor of JBJS is telling us we have options here. So that's great. So send us some ideas. But, I want to talk to you, if I could, about something we did on the weekend at Ortho Evidence. And we put out a short piece, a thought piece on primarily platelet-rich plasma and mesenchymal stem cells. But I don't really want to spend time this morning talking to you specifically about the results and the evidence around that, but more around how do we set standards for these novel biologics. I mean, you have seen many, many biologics tested, and many come and many, many go. So this was more of a discussion I'd like to have with you around what is the state of affairs of how we even decide what works and what doesn't, with the focus on this. But let me give you, if I could, a couple of quotes from that particular insight. That was the August 21 of 2021 insight, which was titled Platelet-Rich Plasma and Stem Cell Therapy, Setting Standards and Evidence. So let me start off with at least a couple of definitions, and then I'll get your thoughts on what you hear here. So orthobiologics, at least by one definition, are substances derived from the patient's own tissues, including bone marrow or blood, that are filled with signaling molecules or cells that stimulate and enhance the repair of musculoskeletal injuries. Orthobiologics could help in delaying or avoiding more invasive treatments. That's, let's say, the overall premise by which we're dealing. Now, some recent work by Murray, Safran, and Laprade, they write, there are now over 400 complete or ongoing clinical trials evaluating the use of PRP and over 800 evaluating the use of mesenchymal stem cells in a range of clinical applications. Many of these trials have been designed and started with little knowledge of what preparations contain, or without comprehensive scientific understanding of the mechanism by which they may produce benefit. Now, Lamplot, Rodeo, and Brophy, and we'll make sure that you get the references for all those who are listening in. Currently, there is a lack of consensus in the optimal preparation, source, delivery method, and dosing of biologic therapies in sports medicine applications. And this is exacerbated by a lack of sufficient experimental detail in most published studies. Now, let me keep going here. Brian Cole writes, many clinical trials have been initiated under this assumption, right, that the promising results that have been attained by preclinical studies would translate into a meaningful clinical effect on professional athletes. Now, although preliminary results of some studies have suggested that orthobiologics may play a role in the management of musculoskeletal injuries in athletes, allowing early return to play, decreased pain, and a lower recurrence rate, other studies have not found that. So here's the point, right? When we talk about this broad area, they go on and they say, and I'll end here and get your thoughts on this. We will only truly know if biological therapies can be of therapeutic benefit if the scientific or clinical community accepts that shortcuts cannot be taken and adopts a responsible approach to the use of biological therapies, including the generation of both an evidence base to support their use and their understanding of the principles of use. I thought they were pretty compelling statements. And no one here talks about the evidence. They're talking about the principles by which we have to move forward. Wondering what your thoughts are on that.
Right. Yeah. So I think it's even more an important topic because we're starting to see some meta-analyses that are showing some effect on stem cells, particularly with cartilage injury around the knee. There was a recent Cochrane collaboration publication on this that did show some effect, but we at the journal have been interested in this, particularly our deputy editor for basic science, Tom Bauer, who's a pathologist at HSS, very knowledgeable in this field. He wrote an editorial for us in 2016 which sounded an alarm over these small one doctor shops that were spinning down patients' blood and injecting into knees and joints and tendons and things. And really the cause for alarm is that what was being published, as you stated in one of the manuscripts you quoted, there was no detail or sufficient detail on how these preparations were being prepared, right, or what their contents were prior to injection. So Tom and many other people in this field have long been interested in developing a characterization checklist of what should be reported on these trials in terms of the preparation of the blood or whatever other tissue, the fat or wherever the stem cells are coming from, and how the cells are treated and what the concentrations are as they're being injected into the patient. And to be completely honest with you, Mo, I'm unaware of how far that movement has gotten. I know there has been some international consensus work done, but to be honest with you, I haven't seen it published, but that doesn't mean it hasn't been done. But this is absolutely essential work that has to be done before we can make advances in this field. We have to know how the material is being prepared and what's in it before we can really look at its effect on patients.
Yeah, I mean, I think we're seeing more and more groups come together, largely because of this, relative popularity, and you can even argue explosion of, groups that are promoting some of these non-operative therapies, especially the more novel sounding stem cell therapies. And certainly PRP, I think, has become fairly routine. I mean, when patients start asking for it routinely, then it becomes, almost a imperative that people provide it, in various forms. The challenge that I've always had is everybody seems to, at least in the early phase of that early, quote, innovation phase of any sort of new biologic, everybody seems to have the magic, concoction, whatever that may be. In other words, everyone says it, but everyone's is different.
Right.
And when challenged, we say, can you bring the data out? So most of us have no problem in, wouldn't say attacking, but providing critical review of other preparations that don't work, in lieu of saying, well, you see, that doesn't work because that's not what I do. Right. The challenge is that, when there's hundreds and hundreds of different preparations at the FDA level, also for licensing, it becomes hard, right? As far as I know, PRP is not regulated as a drug, but more so as a device. And therefore, people are patenting the process rather than the actual dosage per se, and I think that's the challenge, right? There is no, it's not regulated in the same way, which makes it very, very difficult. And I suspect the same is probably true of stem cells. But again, I'm not by any means an expert in this area. I think you're saying the same. The broader issue for both of us is, you get papers coming in with stem cells, I'm sure, all the time. You get papers coming with PRP. How are you deciding, whether, what's the filter that JBJS is using at this point to decide whether something, because, it has huge impact. A small study, even if it's, quote, a randomized trial of 20 patients, if it's done with methodological limitations but suggests a huge benefit, it is going to have an impact. I always say the most dangerous thing about randomized trials, even the bad ones, is that people believe them. They believe them, right? Yep. They believe them over everything else. And so I wonder, as gatekeepers in a way, how do you manage some of the stuff?
Well, it's got to be methodologic rigor. And of course, a small 20-patient trial on a very, very common patient condition is going to be pretty much rejected outright. But along the lines of the editorial that Tom Bauer wrote, now some 5 years ago, right, we really demand that a full disclosure of how the blood or the cells were prepared and what was the ultimate contents of that preparation before it was injected into the patient. those are really the standards before we will consider publication. It's got to be reproducible. And without those details, there's no way it can be. And we're trying to assess results and impact on patient functional outcomes without knowing if it can be reproduced. So we've got to insist on that level of detail as we move this field forward, which I think, it's in more widespread use than any academic eggheads like you and I understand. And I don't think the number of small shops where people are doing these injections has decreased. So the need for higher quality evidence that your publication and mine is responsible for is there. We have to maintain these standards so that we can appropriately inform the public as to what can really work and what can't.
Oh, absolutely. And I think the argument also is that, so there'll be individuals, I'm sure, listening who are, quite favorable towards some of these treatments and are saying, oh, they just don't know, or, that's what the quote academic world says. They just attack something without actually, seeing it in action, so to speak. And I think both of us, and I won't speak for you directly, but my impression is, like, when I look at the evidence for, let's say, for PRP, it has very wide confidence intervals. So it does work in some patients. I mean, it works miraculously in some patients, and in others, it seems to have no effect. So the average effect is still pretty good, but there's so much variability or noise that I think the challenge to those individuals who are, and surgeons who are out there using it regularly, is to collect data responsibly, provide that data, and do it in a way where they're genuinely at some sort of equipoise, where, set up a system where it isn't just absolutely engineered to show a positive result. Show a system where you genuinely, can prove that if it works in this population, we should be using it. Because I don't think anyone here would argue if something is of benefit, you should use it. And for certain, there is likely some formulations that seem to have a greater impact, given the fact that it's been sustained over some years now, and we're seeing more and more come out. The challenge is, in an unblinded patient situation, there's so much influence of just the hope and the desire for something to work that it's hard sometimes to uncouple that with the actual biological mechanism by which something is working.
Right. You and I have discussed on a prior issue of Ortho, Joe, the placebo-controlled trials, and this is probably a place where that should probably be the standard, so we have placebo control.
Right.
It would be a minimal risk in terms of an injection. So it would be important if researchers would consider this.
Well, even on that topic of placebo, right? We often just think of placebo as saying, okay, well, someone gets the treatment, the active treatment, the patient sees I'm getting something, and then the patient also sees I'm getting some sort of an injection. So I'm getting 2 injections. Right. But there's a very vast difference. I think you can even uncouple the aspect of the placebo effect. So imagine this, from your perspective, Marc, you have, two people say, okay, I'm going to give you an active PRP, and they see you come in. I mean, I'm going to go extreme here. You come into a nice clinic, white coat, throw a stethoscope around your neck, whatever, right? Look a professional, have some charts, and then you do the mixing, right? And then you do that. You grab the violin, you tap it, and you show them the layer. That's the good stuff. Yeah. Right. And then you inject it. Now imagine if you just took all of that away, just that whole sense of, oh my goodness, look what's happening. Something's being extracted and I'm seeing it. I'm seeing this whole laboratory effect happening.
A bit of theater, really.
Well, I think there is. So there used to be a magician you might have heard of called Doug Henning. Yeah, he was a Canadian. Yeah. And so in my mind, I know there's a trial happening locally in Hamilton called Evaluating the Doug Henning Effect, which is kind of it's magic, right? Kind of stuff. And I'm not saying it's not, but I do think even within the placebo effect, that if you were to take away a lot of that perception of if you just get a needle versus you get the whole, you see the approach, right? Yeah. Let's say you're getting an injection of a corticosteroid. Well, you don't get the preparation, you don't get the spinning down, you don't see the layer. Now, I'm not saying patients are all shown this, but if you were, it's just one more additive impact to this is going to work. Now, am I saying that this is all hocus pocus? Not at all. No. I'm just saying that there's an element here that we have to uncouple and try to understand it. And that's all it is. And I
Yeah.
genuinely believe that in all of these areas, there's going to be huge benefits that come from it. And I just hope that those academics out there and and the users, the practitioners who are using it and believe so strongly, will partner on trials to really demonstrate the value of what they already believe is happening for their patients.
Right. We need better evidence, and that's what OE and JBJS are all about. So. Yeah.
All in. But anyways, I thought it was an important little discussion that's happened. I'm happy we've had it. And if any of the viewers, listeners have comments, please, if we're completely out to lunch on this, educate us. And you get a free cup. You get a cup too, if we talk about it. Come on, you want your cup. So anyways, Marc, that was great. Thanks so much.
Yeah. Have a great day.
You too.
Yeah. Bye.